Welcome, everyone. My name is Bill Mallon. I am an ophthalmologist in Vero Beach, Florida, and I am co-founder and CEO of GlobeChek. I appreciate Topcon giving me the opportunity today to speak about our product, which we believe is really the future of teleophthalmology. So currently, teleophthalmology consists mostly of fundus photography, and certainly it's a step up. We're doing something, we're getting out there, we're trying to figure out what people have pathology, diagnosing that and getting them referred. But there are some significant limitations to fundus photography. There are certainly pros. It's portable, it's inexpensive, it's easily accessible, readily available. But some of the cons are we really don't get the full picture. We're going to misdiagnose things, we're going to miss a lot of things. So we look at this, we've got a great fundus photo. Is this normal? Does this patient have any eye disease? We really don't know. We're not getting a full picture. So obviously this patient has some pathology that we did not pick up based on a fundus photo. They've got a 6 nerve palsy and potentially a neurological problem. This patient has a normal fundus photo, but has an obvious ocular problem on the right, a cornea problem and a cataract that is misdiagnosed and undiagnosed. This patient has a large cancer on their eyelid that we didn't pick up. This patient has a pterygium and possibly a squamous cell carcinoma on their eye that we didn't pick up by fundus photography. As we move on, again, common theme here, we're missing a lot of things. So this patient has obvious thyroid ophthalmopathy and needs a referral to a medical doctor. We're also not picking up refractive errors. So this patient, obvious high myope, but we're not picking up presbyopia. We're not picking up hyperopia. So patients who are just in need of eyeglasses, who are walking around with uncorrected vision, and they are many. We're not picking any of that up with a fundus photography as well. And one of the big things we're missing is glaucoma. We're not checking an eye pressure. So we've got a normal fundus, we've got a normal looking optic nerve, but what are we missing? This patient with an obvious eye pressure elevation could be walking around with a time bomb ticking and losing vision from glaucoma. So we've got a normal fundus photograph here. We've got an OCT that shows obvious optic nerve disease that's not picked up by the fundus photo. Get another patient, normal looking macula, obvious vitreomacular traction. Now, before we do cataract surgery in our practice, we do an OCT on every single patient. We want to know what's going on in the back of the eye. And I can't count the number of times that I do an OCT, I swear the macula looks completely normal, and they've got this problem right here. Not a good candidate for a multifocal lens. Last thing we want to do is put a multifocal lens in this patient, and then afterwards try to explain why they're not seeing well. So lots of pathology we're missing just looking at the fundus, taking a photograph. Another patient here, this patient, normal looking fundus photography. We look over here and we see retinal thinning on one side. This patient had a branch retinal artery occlusion, and after the acute event, you're not really going to see the pathology. You're going to look and see a normal retina. But without visual acuity, we don't know that this patient is seeing 2200, has no central vision. We're just looking at a photograph. Looks normal. Obvious macular drusen. Obviously, we'd look at that and we'd say this patient is at risk for macular degeneration. They're going to need a referral, but is that an immediate referral? What's their vision? We don't really know. Are they seeing 20/30? Are they seeing 2200? We do an OCT and we see that a patient has wet macular degeneration and they need an acute referral and they need treatment immediately or they're going to have vision loss that's going to be permanent. Another patient here, diabetic retinopathy. That's really the big impetus for screening exams and for fundus photography. That's really what the model of teleophthalmology has been set up for now, is to look and pick up diabetics. So we look here, we've got a patient, they've got a few microaneurysms in the fundus, maybe a few dot blot hemorrhages. What's the extent of that? We really can't pick up on a fundus photograph what's the extent of their diabetes. This patient has clinically significant macular edema and really requires immediate treatment, or they're at risk for long-term vision loss. Again, what we pick up in a fundus photograph is not adequate to really diagnose this. So what do we really need? How do we make teleophthalmology better? What is it going to do? What needs to be included to give us a thorough picture of the eye? Well, we need visual acuity. We need a fundus photograph. It's an integral part of what we're doing, but it's not the only thing. You know, if I was going to go to my primary care doctor and get an exam, if he just picked up his stethoscope and listened to my heart, and he said, "We're done." So well, what about my blood pressure? What about looking at my body, looking at a physical exam and figuring out what else is going on? So we're getting a very limited picture. It's important, but it's not the whole picture. So we need OCT. We need an OCT of the optic nerve. We need an OCT of the retina. We know that that is very, very important to really diagnosing what's going on. We need to check the eye pressure. How do we do that in a clinical setting? Well, we need a non-contact tonometer. We can't be touching patients' eyes out in mass screenings, but we need to get an eye pressure. We need an autorefraction. We need to know what their visual acuity is. So we need to know what their refractive status is. So if their vision's 2200, are they hyperopic or are they myopic? Are they presbyopic? These are all things that we can pick up. And we need an external photo. We need a high-resolution external photo to see if there's something going on. Do they have an ectropion, a ptosis, a cancer on their eyelid? These are all things that are really important to give us a thorough screening. And we've answered that with GlobeChek. So we've taken all of these tests and we've put them into a single product that is allowing us to scan people in a very thorough fashion. So we've included every part of this, all these tests, in our GlobeChek prototype. So what is GlobeChek? It's a comprehensive eye screening. It's thorough. It's very accurate. It's cost-effective. It's fast, and it's very efficient. These are all things that we need to do to make screening comprehensive and readily available. Why aren't people getting eye exams? We know 80% of the people in the United States do not currently get eye care. So how do we reduce that? How do we get that number down to a very small number? How do we tap into that 80%? We've got to make it readily available. We've got to make it fast. We've got to make it efficient. And we've got to make it cost effective as well. So we've got to eliminate those barriers. GlobeChek will eliminate those barriers. This product will be placed in high traffic areas, malls. It'll be in airports. It can be pretty much anywhere. We've got a mobile version. Doctors can take this around and go to schools, can go to nursing homes, can go to places, outreach to patients in areas where they just don't get eye care, where it's very easy, it's very difficult to get to somebody. And Topcon has a great group of instruments that we've been able to incorporate into our Globe. Very efficient, answers the things that we needed. They're able to be automated. They're very fast. They're high quality. And we appreciate that partnership. So how does it work? Well, patients will show up wherever we see them. They'll walk up to the Globe. They'll be scanned. Their information will be sent to a reading center where an ophthalmologist will be reading that scan. And then the patient will get that report. On the report, they'll have a comprehensive eye screening. It'll give them a diagnosis. And then, okay, so they've got this diagnosis. Now what do they do with it? Well, on the bottom of the report, they will be referred. So if they're in an airport and they're traveling, they have their exam. At the bottom of the report will, based on their zip code, give them a list of physicians that they can see in their area. They'll be able to go to that list, click on that report, share that with the doctor, and the doctor will also know why they're coming into their office. So within 24 hours, this is the report the patient's going to receive. They're going to get their distance and near vision. They're going to get an autorefraction, eye pressure, external photograph, optic nerve and macular photographs, and OCTs. Telemedicine. You know, it's interesting when we talk about telemedicine, and this really started with Dr. Katz and I sort of joking that we were all going to be replaced by kiosks in the mall. And then we looked at this and we said, well, not really. What we really need to do is look at how are we going to reach out to people? How are we going to stop people from walking into our office with 0.9 cups and pressures of 40 who are 45 years old and had no idea they have glaucoma? Or they walk in with macular degeneration or diabetes and had no idea that they had an eye problem. So we realized there's a problem out there. We've got to reach out to people. We've got to create something that is going to allow people to get screened, pick these people up, and then be able to treat them before they lose vision. But when you present teleophthalmology to ophthalmologists, immediately their first reaction is, whoa, I don't want this. I'm afraid of it. It's going to put me out of business. And the exact opposite is true. So people need to stop running away from telemedicine, and they need to really embrace it. So there's a recent article by the American Academy, and in there it stated that 59% of ophthalmologists had reservations about teleophthalmology. 100% of ophthalmologists should embrace teleophthalmology. What are they afraid of? They're worried that it's going to be decreasing the quality of care. There's too much liability. I can't do this. What's going to happen? I'm going to get sued if I miss something. Is it secure? Are people going to hack into this and their information is going to be out there? How does it work? How do you seamlessly take care of people and get them the information they need? And what about the quality? Well, you know, what if the image isn't good enough for me? Well, we've answered all those things. It's quality of care. We've got a great scanning device. It's going to give us great images, just like if you were in your office. Liability. Look, we're going to pick up eye disease that presently people are walking around with time bombs in their eyes. So if we're able to save one person from going blind because they got scanned, we've done something good for people. Security. And by the way, when we let people know, this is not a substitute for an eye exam. This does not replace your ophthalmologist or your optometrist or your eye care provider. This is a way to screen, to identify disease, to get you to the right person. Security, it's all HIPAA secured, and it's all encrypted. So there is no issues with security with the data. The workflow is seamless. Patients are screened. They get the report. They're told where to go. They're given options and opportunities to see doctors. And the image quality, we've answered that with the equipment we're using. Topcon has top-notch equipment that we're able to use. So really, you know, doctors should be ramping up. They should be increasing their staffs. They should be thinking about bigger office space and figuring out how they're going to handle the increased workflow and the number of patients that are going to be coming to their office. If we tap into the 80% of this country that doesn't get eye care, and we realize with our studies that over 25% of these people have eye disease that needs care, what are we going to do with all these patients? This booth is going to need to be 3 times the size with the amount of business that's going to start increasing to ophthalmologists. So we're going to see increased patient referrals. We're going to save site, and this does not compete with ophthalmology or optometry. The professions are secure, and they're going to be bolstered by teleophthalmology. So every doctor in the world should be part of the GlobeChek network. We're creating a network of interconnection across the United States and across the world that allow, you know, almost a Facebook for ophthalmology. You can reconnect with your colleagues, mentors, friends. You can share, you can post challenging cases. You've got something in Egypt and you want to get an opinion. Did anybody ever seen this before? You can post this on GlobeChek. Doctors will have access to that. We can start establishing standards of care across not only just different states, but different countries. How should we be taking care of these patients? We can learn about new techniques. Somebody's got a new technique, they can post it on GlobeChek, and the entire world of ophthalmology can see that. I get asked many times, I live in Florida, I've got patients who are moving to a different location. They're going to move to Kansas, and they need a doctor. How do I get that? I go to GlobeChek. I look up, I find doctors in Kansas. I can refer that patient through the GlobeChek network. The patients can take their records with them as part of their GlobeChek profile, and they walk into a doctor's office. They're not having to look for the medical records. The patient owns them, has them, shares them with the doctor they're seeing. Check on upcoming meetings. You know, who's going? Are any of my friends going to the meeting? And emergency care. You're traveling in Europe, you're on vacation, you wake up in the morning and you're in Rome, Italy, and you can't see out of your left eye. What are you going to do if you're living in the United States? You don't know anybody in Italy. You look up your GlobeChek app, you go, you find a GlobeChek doctor, you click on that doctor, you're able to get to that doctor's office and receive the care that you need. That's it. Any questions? Thank you.